Over to Dr. Lalit Verma. I'm really grateful that you could make it to the IC, sir. And he'll be talking to us on can surgery be the solution for unending injections for DME?
Thanks, Chitra, for having me here. And DME today is synonymous with injections. Whether retina surgeon, anterior segment, comprehensive, anybody who sees DME, preferably OCT is done, and time domain OCT, they'll keep injecting, and patient is scared also. And he comes to retina surgeon in the last time, Dr. Sahab, bahut injection ho gaya, what to do now? And then Mangat was hinting at Ozudrex. Mangat, Ozudrex is your first choice or in first choice? So people, people come with this kind of picture, and obviously they tell Dr. Sahab, 12 injection ho gaya. And today, interval injections, honestly speaking, I will not hesitate to say, have become one of the main source of revenue generation. Faster revenue than cataract surgery also. And people keep giving irrespective of the picture. Diabetic hai, thoda sa swelling hai on the macula, keep giving injections. Sometimes without any rationale also. And this is one of the chart which my patient came, Dr. Sahab, itne sare lag chuke hain. And this is one eye, right eye, left eye. So patient gets exhausted actually, exhausted. You see, if somebody else is paying, it may not matter. Then patient will say, okay, Dr. Sahab, laga do. But if he is going from his own pocket, because in India, insurance penetration is not very high. So that is the reason, you see, it pinches him a lot if so many injections. It's a endless kind of disease. And this I copied from Google that the sale of these injections are so high nowadays, and every company, biosimilar, they will keep coming to you, promote this thing. And we have to be very, scientific in our approach and show genuine concern for the patient. You see, if I am a diabetic or my father is diabetic, what will be my approach to, this? And consider economic factors, his paying capacity, and use very judiciously so that we can maximally benefit him. DME is not a single entity that all of them will have one approach told by Chaitra Jaydev, by yehi sabko karna. That's not possible because there is a myriad of presentations. So many presentations may occur. Like Mangat was saying, one patient refer it to your enemy or whatever. So there's so many presentations. And it's a multifactorial disease. It's not only glycemia which plays a role. Hypertension has been shown. In fact, the work done by Mangat when he was in PGI was world-class work and quoted very often internationally and published in very high journals. Role of lipid profile, hypertension, even anemia. It was highlighted by their paper. Then glitazones, especially pioglitazone implicated, sleep apnea, cataract surgery is already highlighted. So it's a multifactorial disease. What I do is I'll scare this patient of diabetes. I'll call all their family members, but because it's not an individual disease, the whole family has to adapt to, if a person lowers HbA1c by 1, it helps quite a bit. So you scare him because diabetes is not going to go away. If he reduces the weight by, say 5 kg or lower, it helps all of us in proper management. So today, diagnosis is not difficult at all. FAOCT, a lot of people do. OCTA, you have heard in the morning. Primary role of doing, the decision has to be made in combination. Because 3 things are very important. Vision, FA picture and OCT. And it's the combined, information from this you have to see. Like if vision is 6/6, I will hesitate unless and until patient has, neostrelation elsewhere or a non-sentinel involving diabetic macular edema where we can laser. But by and large, you do pay importance to how much is the vision. In fact, the recent study by DCR Net that showed that in patients who have good vision, 6/6 or 6/9, heavens are not going to fall if you wait for some time, in instituting treatment for DME. The role of angiography is specifically if you have to laser. Because OCTA may provide information, but I would still today depend on FA. If I have to do laser in a patient, especially focal laser, I would like to pick up those leaks. Although flow studies in OCTA may tell some information, but I still want an FA. FA is not dead even in the era of OCTA. And role of OCT to my mind, apart from picking up various 5-6 categories of edema, is to rule out traction. You see, if you see picture on the top, this patient, you keep giving injection, nothing may happen. The top picture, there is an active pull on the macula. Then various categories of edema have been advised, cystoid, cystic. Some people may prefer steroids in a cystoid. So based on all this, whatever you have done, I would like to classify DME into tractional and non-tractional or combined. Tractional further classified into with vision loss or without vision loss, and non-tractional further divided into center involving and non-center involving, because that has a bearing. So this patient who was already lasered also had this edema. So one shot of anti-VEGF did decrease, although edema didn't go away completely, but it did help. So this patient was fed up of so many anti-VEGF injections. So we gave one shot Ozurdex. So he was a happy man, a banker by profession. So this lady had again multiple injections. So we gave Ozurdex multiple injections. This picture, last picture, is after nearly 12 months of third shot of Ozurdex, and even though there was some vitreomacular traction, but edema did go away. Vision improved modestly only. Her best corrected vision was 4/60 at the last follow-up. So what do you do if you have traction edema without vision loss? So without vision loss, answer is observation. Do not attempt to remove tractions, all the tractions which are there. So ultimately, function of the eye is vision only. So don't do heroic attempts to remove this traction, which is predominantly nasal here. So this patient is best kept under follow-up only, because vision is pretty good. What about patients who have traction edema but with vision loss? So here, generally surgery is the answer, but some people, I will show you one example. This was my patient who had injection, diagnosis as tractional macular edema. So as we were preparing, I gave injection, but fortunately this hyaloid got separated. So this is not a very common occurrence, but it can occur. So you can attempt, I'm not saying this is treatment of choice, but sometimes you can. So this patient resolved, edema resolved, everything went away, surgery deferred. So surgery, what kind of surgery you do? I think it's a standard MIVS surgery, 25 gauge surgery. You put tricot to peel off the hyaloid in a patient who has traction edema, and try to gently increase the suction, engage the hyaloid face, and this hyaloid does come out most of the times in a single. And after you have removed the hyaloid, this patient had cataract also. A lot of times we combine cataract surgery. Very important, you have a good cataract surgeon, like Mangat was saying, you have to have a very good cataract surgeon at hand also. And after this nice cataract was done, pupil was still good. So we went ahead and put trypan blue here to identify the epiretinal membrane. So I normally put trypan blue under air, and 1 or 2 drops normally suffice. So then I take this 25 gauge MVR blade to identify the edge of the epiretinal membrane. Here you see the edge, and once edge is there, you are very confident that you will take a forceps and then remove, as is being shown here. Take a forceps and this epiretinal membrane will come out. Next dilemma is whether after removal of ILM should be done or not. By and large, most of us do attempt to remove this ILM. And here I am showing this direct pinch and peel technique where ILM is being removed. And I am making multiple flaps initially of ILM, and try to remove from the entire posterior arcade. Once you are inside, try to do the removal of ILM in a complete way. So here we have this is a BBG assisted ILM removal. And in this patient, there is not much surgery done, so we ultimately did only air fluid exchange and gas injection and did not do any oil. So this was one of the patient who was unhappy, and her OCT was like this. So we did this assisted with tetmi MIVS, and she was a happy patient. 360 to 6/18 she recovered. This was another combined detachment, but you see the OCT picture pre-operatively and post-operatively. This is again foveal contour restored. So DME patients, you need not keep giving injection. Sometimes surgery, specifically with active traction, does help. So non-tractional, this was tractional. Non-tractional, now coming to non-tractional DME, center involving DME. Highlight, I agree, anti-VEGFs are the drugs of choice. You have choice between various molecules. We will not discuss which one to use. Biosimilars are also entering in a big way. Then Ozurdex and lasers also are there. And after, even in non-tractional DME, suppose you have exhausted all the things. You have paid attention to metabolic parameters, injections, Ozurdex, everything has been done. sometimes you still consider vitrectomy in a non-tractional central volume DME. Because there have been a lot of reports now. This data again, taken from the net. Definitely in tractional it does help, but even in patients who have DME without traction, so although anatomical success is more than the functional, but it does sometimes put an end to the injections. So my topic was how to put an end to injections. So this may help. So just to conclude, DME today is not blind injections and injections. Consider various factors. Consider the metabolic profile. Consider all the things before you pressurize patient by injection like wall. A lot of people call patient by eye up time penny eye. So this is the last slide. Tractional definitely PPV. In non-tractional, after having fed up and exhausted all the things, you can consider vitrectomy. Thank you very much.
So I have two quick questions. One was when you're doing the ILM peeling in the setting of a DME with a probably central large foveal cyst, would you do ILM peeling in any other way?
No, what we do is we do not actually, we do a foveal sparing kind of ILM. And because it's not like I showed the traction, if you pull ILM, you may de-roof the cyst and create a iatrogenic hole. So it's just leave it at the edge only.
And then you trim it with the cutter.
Yeah, trim it with the cutter. Use 50 as suction and highest possible cut rate and trim it.
Never across the
Never
fovea.
across.
So that's one important point. And second thing is, sir, have you actually gone ahead and done any vitrectomies for resistant DMEs?
And on resistant, only 2 patients.
Okay.
Only 2 patients.
Any other experience from the
Because that is not,
audience,
you see, I haven't, because this becomes the choice if you keep getting good results. Because the results in non-tractional central volume DME patients who are fed up, so let the patient beg for it, then you do it. Because if you propagate and don't get good result, then patient will be an unhappy patient.
At least I have had a problem, although I have stopped doing ILM peeling in diabetic macular edema because I had 3 patients where the fovea became so thin and their vision went down. Maybe it was more related to ILM peeling, and these are the cases where they were non-tractional. So at least I don't do it for quite some time now.
I agree with you, Mangad. Most of the patients, you see, ILM in macular surgery is totally different ball game. ILM peel in non-macular is different. And most of the times in diabetic, the kind of video I showed, this was one video which ILM came very easily. A lot of times you have to struggle, or it may come piecemeal, small bits of ILM. It may not come as it comes in macular hole. So I do try, but I do not insist. I will not, keep doing. If in one go or, I take out the edge, so I'll just loosen that. That's all. I agree with what Manga said.
Yes.
Yes, sir.
Yes, please, Dr. Apte.
Great talk. So I think that's the most challenging patient, the one that says no clear evidence of traction. But I think that's a really, like you said, a patient discussion, because as long as you're counseled well about the vision may not improve, maybe reduction in number of injections.
Yeah.
Because if you went back to what we published with Protocol D, which is not the best study, but we couldn't tell the difference, whether they had an ERM or not. So I agree. I think unless you have a really good discussion, you could have these situations with severe foveal thinning and
I've even seen somebody doing surgeries for removing the plaque, the hard exudate plaque at the fovea. I don't know if anybody has really tried that. And
I read about it in Japanese. A lot of these Japanese used to do that and tease that plaque. I don't have guts to do that, and because you see any manipulation on the fovea or around the fovea does not give good results.
Yes.
At all. You compromise on the post-op vision. I'm 100% sure about this.
Yes. While I request Professor Atul Kumar to connect his laptop for the presentation, sir, is this your first instruction course as president of AIOS?
Second,
damn. I was hoping it'll be the first. Anyway, sir, thank you so much and congratulations from all of us to taking over as the president of AIOS.
Thanks a lot.
Really privileged that you are part of
all
our
your good wishes and feedbacks and what all needs to be done.
Absolutely, sir. We are all with you. Thank you so much.